Welcome to Same Surgeon, Different Light, Season 6. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast series. My name is Sara Pereira, and together with my co-host Cherie Erkmen, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We will explore their journeys, the obstacles they've faced in their careers, and the qualities that make each cardiothoracic surgeon distinctive and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.
Same Surgeon, Different Light is brought to you by the Society of Thoracic Surgeons Career Center, where you'll find free access to cardiothoracic surgery jobs, career development tools, and professional guidance. Visit the STS Career Center at careercenter.sts.org.
Welcome to Same Surgeon, Different Light. I'm Dr. Sara Pereira, joined by my co-host, Dr. Cherie Erkmen. We are so happy today to welcome our guest, Dr. Gianluigi Bisleri. Dr. Bisleri is an associate professor at the University of Toronto, cardiac surgeon at St. Michael's Hospital, and an investigator at La Ka-Shing Knowledge Institute. We are sitting down with Dr. Bisleri today to talk about his career, which has been defined by curiosity, reinvention, and innovation. From his early training in Italy, where he once imagined a future in music, to fellowships at Columbia University and leadership roles across Europe and Canada, Dr. Bisleri shares a unique path marked by bold transitions. He discusses advancing minimally invasive valve and atrial fibrillation surgery, training as a left-handed surgeon, and building innovative programs from the ground up. In our candid conversation on leading change, he reflects on introducing new technologies in complex academic settings, mentoring the next generation, and embracing resilience, lifelong learning, and balance. Lessons shaped by his family life in Toronto, skiing Canadian winters, and playing guitar in a band. Cherie, I'm so glad to be sharing the stage with you today and welcome our international audience, particularly from Canada.
Great to be here, Sara. It's always fun to meet new people. Today, we're delighted to welcome a special guest, Dr. Gianluigi.
Thank you very much, Dr. Pereira and Cherie. It's really a true honor for me to be here and to have this conversation with you and the STS audience.
Dr. Bisleri, we met last year at a national education course on the West Coast, and I remember being immediately impressed with your dedication, not only to minimally invasive valve surgery and education, but you had this really amazing new simulator that I thought was really cool and must have taken some time to develop. So both the technical skills as well as education are really tough to master in our specialty and require really great patience. So you've been able to bring your technical mastery of mini mitral repair to all residents and fellows in Canada and develop this new simulation product for minimally invasive cardiac surgery.
Well, thank you, Sara. This is and I think a very important opportunity I had when I moved to Canada to really be able to expand on an area of professional focus for me, which is minimal invasive cardiac surgery, especially on the mitral valve. Obviously possibility, especially here in Toronto St. Michael's Hospital, to grow the expertise and to grow the number of patients that we can offer this treatment with has been incredibly important and growing over the years. And similarly, the opportunity to share together with surgeons across the country, but also with surgeons in training, so that we can help continuously expanding the pool of surgeons that can hopefully offer minimal invasive cardiac surgery to patients. I think that the part is very exciting, not just in Canada, but with a more international footprint, since many of my fellows are actually international fellows. So I think it's extremely gratifying to see this can be translated into their own home countries.
So I'd like to talk a little bit about that. You have an international background yourself. Can you tell us a little bit more about the you before you became adult cardiac surgeon and innovator?
So, if you're asking about my background, my started obviously my life and career in Italy, where I grew up. And what's interesting is talking about interest. My very first interest was to be a musician. And what's actually I find interesting about that aspect is that I'm naturally a left-handed person. When I started approaching cardiac surgery, and I was fascinated by cardiac surgery as a medical student in Italy, and I attended the operating room, um, I faced the typical struggle that many left-handed surgeons do, which is it is difficult to get appropriate training. And I was kind of suggested to start thinking about using my right hand. And as you can imagine, you're like, I don't know, 21, 22, I was a medical student. It's not easy to start now using your non-dominant hand. But the good thing in my case is that I played piano since I was 5 years of age. So I actually had a fairly good use of my right hand since I was a young kid. So it was just a matter of slightly refocusing. And I think that's, I believe, also an important story, how things can collaterally help you in your career that you wouldn't connect the dots at the beginning. And also, I actually think as often challenges can actually empower you because I focus so much on my right hand that now it has become my dominant hand. When I walk into the OR, I barely think about using my left, but over the years, I learned how to use both. So now, when I teach, sometimes it's slightly more difficult because I either have right-handed or left-handed, and I use both. So I have to fine-tune my teaching to whatever the dominance is of the trainee. So again, it's an interesting, aspect of how life can be taking some turns, so to speak. And then, as you mentioned, I studied in Italy. Again, interestingly, I studied medical school in Italy, but I always studied in English, on English textbooks. And my schoolmates were kind of teasing me about this extra effort I was taking, because obviously that was not required when I was in Italy to study in English. But I always had this idea, this vision of potentially having an opportunity to explore medicine outside of Italy. And I did. As you mentioned, I studied at Columbia University for a fellowship, then in the UK, and then finally Canada.
And what was driving you to different locations? What was it that made you seek opportunities outside the comforts of where you already were?
So, well, there were different, I would say, motivations at different stages. When I went to, and I was fortunate to have the opportunity to work at Columbia University, that was back in 2003. And at that stage, I would say, I would call, as you probably most of us remember, was the first wave of, robotic surgery, minimal invasive. Interestingly, that was my first interest started with robotic surgery, and I attended this fellowship research, but also with some clinical exposure with Dr. Argenziano at that time at Columbia University Presbyterian Hospital, and that was already a way to start exploring really the dawn of robotic and true pioneering minimal invasive cardiac surgery, as well as atrial fibrillation. I actually went back to Italy with a very important learning point, which was totally endoscopic atrial fibrillation surgery. I actually, together with my partners in Italy, we were the first center in Europe to do totally endoscopic cardiac surgery. So that was, again, a very important aspect in bringing something that has been part of my career for many years. UK was a way after my residency to, broaden my perspective with another, European country and different professional experience, which was great as well, working in the English system. And it was really helpful, again, with a strong focus on, I would say, quite consistently minimal invasive cardiac surgery. Finally, Canada was I was already staff in Italy, and it was related to the opportunity to help expanding the breadth of minimal invasive cardiac procedures in a country which only had very few centers. Now I can tell you I've been working for almost 10 years in Canada, and the landscape has changed and is continuing to change. But literally, when I moved 10 years ago, probably was just your handful of surgeons, not even centers doing minimal invasive cardiac surgery. So I think being part of this um, new era of minimal invasive cardiac surgery in Canada has been an incredible experience and opportunity.
I really admire your challenge of yourself to move and start new practices. I've never been afraid of moving and taking on new challenges because I think that you learn something great everywhere you work. But we have a lot of surgeons that stay in the same practice their entire career. So how have you really challenged yourself to take on new opportunities such as you are right now? And I should add that you've been back initially at Queen's University in Canada, but now at University of Toronto over the past 5 years as director of minimally invasive surgery. And so you've created an entirely new team where you are and developed minimally invasive surgery at University of Toronto. So how have you kind of forced yourself to start new practices and move throughout your career?
Well, I think it's really a very important point you're raising, and I personally find that uh, it goes back to, again, probably a personality trait, which is also curiosity. And I find that I'm always interested in learning and exploring in general in life, and of course, this reflected on some professional choices, like embarking, as you mentioned, in something which is not easy because you have to build, um, I think, different aspects in your career, like when you're moving into a new institution, and especially depending what the goal is in your transition. It's different if you're joining a team and progressively, scaling up your professional growth, or you have to establish something more, I would say, demanding, like a new minimal invasive program, especially like one of the exciting part for me in Toronto is that Toronto is, as you know, has had and currently still has many world-class cardiac surgeons, but Toronto did not have any minimal invasive program. And I was the first one to introduce that in the city. But besides sometimes overcoming concerns or challenges that people may have in general every time there is any major change, because you obviously are bringing people out of the comfort zone. I think it's also a very important life experience in terms of team building. The we tend to focus a lot in our journey, I think, as surgeons, how we master some specific technical skill, and I think part of our and it is already becoming part of many conversations. But I think I always try to give an important component to fellows working with me about those soft skills about building a team. And I must say myself, if I may share my experiences, that sometimes um, the uh, the things I would have done differently in a pathway when building a program, sometimes you have a timeline which is in your head, but you have to work as a team and you have to progressively bring cohesively the team around you in supporting and being excited. And it cannot just be your own pace. Driving the change. It requires resilience because obviously you want to be doing that in a constructive way, and not be or become frustrated. So I think it's important to keep the motivation, trying to understand everybody around you. And that's actually also part of how people should look into their job opportunities as staff. You don't simply want a job position for the sake of maybe simply checking a box, but also having, if you're looking at certain professional pathways, to make sure that that environment can support you. And then it's really your own duty to make sure that this translates into a reality.
Do you have any good tips for Cherie and I that you've used again with your hospital administration to move your minimally invasive team forward? What was the best advice that you can give?
Well, I don't know. As I said, I think it's difficult to find a common maybe recipe that can work for every institution because different environments may have different triggers to obviously be motivated. But I would say trying first of all to make sure that what transpires is that you're not there, for example, in my case, for the minimal invasive, just for your own personal sake of establishing a program, but why really this is impactful, how much is for patients, and how I think carefully things are planned. Because obviously, every time we all know in cardiac surgery, you move away from the sternotomy, there is often a perception of concerns or risks for people, and trying to demonstrate the safety and the thoughtfulness in how everything has been planned is important, so that people are actually uh, genuinely buying in your vision and understanding that this is carefully planned. I think that if the first steps are followed carefully, uh, the demonstration becomes by the referral itself that patients, and not only referring cardiologists, but patients do demand this and are um, obviously hoping for these opportunities. I also find, and sometimes I find this an interesting aspect that competition is also a very good aspect to actually drive innovation. And for example, I must say that Canada has a relatively low ratio between centers and patients, meaning that we do have a large catchment area compared to the number of centers or volumes compared to the number of centers. Unlike other realities, probably like US or Europe, Italy for sure. Um, and I think that, for example, for me, working in a place like Toronto, I've been welcoming other centers stepping up to, so to speak, the opportunity to develop a program, because it's always an incentive for us to keep, continuing evolving. And I find that as long as things are done in a respectful way, this is always a nice way to continuously challenge ourselves to the point you were raising before and trying to give our best.
I wanted to pivot to your experience as an innovator to that of an entrepreneur. You have 3 patents and a lot of different simulation tools. When you are, how do you get from a great idea to actually a patent, and then beyond a patent to a product that can actually be accessible to people?
Well, I think, Cherie, you actually touched a few very important points that I'm sure most of surgeons I think most of surgeons had the opportunity to come up with some great ideas that could potentially address some of the challenges we're facing. But this is exactly where the difference between having an idea and turning into reality really strongly creates like a major, diversion, so to speak, in the pathway. I was very fortunate when I had the opportunity, uh, let's say, to really have get the bullseye on my first strike, so to speak. I was a resident, and I came up with an idea of a retractor for a endoscopic vessel harvesting approach for the radio. And I approached a very renowned large medical company, international medical company. I went to the booth. I was very naive. I was 26, 27, didn't know anything about NDAs. I would probably, in retrospect, would have done things differently these days. But I was fortunate that they actually said, "Well, that sounds like an interesting idea. Why don't you come to our headquarters?" And what I learned, and I'm actually grateful. It was not that much for me financially, obviously, the turning point in my life, but it was a very important aspect because I learned sitting down with the industry, learning how the challenges are. Then to the point you raised, how is the R&D process for this instrument? How much is going to cost at the end? Not just how good the idea is, how widely can this be adopted? And I must say that as surgeons, we tend to focus on, oh, we have a problem, we may have a solution. It doesn't really matter how much it costs to develop that idea or to actually make it marketable. So we lack that, I think, nuances as surgeons to understand why sometimes there is a challenge in bringing certain products to market and to wider adoption. So for me, besides that opportunity to have a patent, and you can imagine at 27, they actually named the instrument after me. So I was already, I'm about to retire. I'm more than satisfied with my career. I haven't even started as a staff, but that I would say professional experience in the product development was incredibly important. And as you mentioned, it really reflected many years later, completely unrelated, not just for other medical devices, but also when I embarked together with some partner into our own ventures of developing a simulation system, because I use that kind of mindset to understand not simply, oh, let's realize a simulator that looks particularly, so to speak, cool, but how can this can become a tool that really answers to questions? How can this be produced in a way that is sustainable and can be adopted by as many people as possible? So I think that we need a little more of, let's say, business training sometimes if we want to embark also in that area.
Dr. Bisleri, I wanted to spend a little time talking about your mentors and how they've shaped your successes. But I guess if you have an instrument named after you and you're 27, you must be the mentor, right? So
No,
of everywhere you've been, who's really impacted you the most in terms of surgery and product development, and what do you pass on to your Canadian residents and fellows?
well, I can tell you that it's quite the opposite. Like I've been influenced and by so many surgeons along my entire career. In a way, I consider myself truly a product or a sort of puzzle made of many pieces of so many people that shape my career. I that really started. When I was in Italy, and my former chief at the time, program director, and also then it was my division head when I became staff. It was Professor Munaretto. It was really he had a strong vision for minimal invasive cardiac surgery, and when you get exposed so intensively, you cannot deny that for sure that must have had an impact in starting to see things always like. Um, why am I even doing a sternotomy? Almost questioning yourself rather than the other way around. Why I'm offering a minimal invasive. So really starting to always chase innovation. And as I said, probably that really was fitting a lot with my personal vision of curiosity and always being trying to chase new endeavors. So it really fed what I was looking professionally in my career. But there are so many people. That really across the pathway, as I mentioned when I was in US, Mike Argenziano was incredibly really helpful in shaping and directing the people I had the opportunity to work with. Dr. Cox. I can tell you that he came several times to Italy, and I always tried, and he was so kind with me to basically steal him from all the others, sit with him, and really squeeze as much as I could from him. And it was so nice, I must say. Before getting to know him personally, how much I made an idea that he was only uh, believing in the maze procedure he designed, but he was so open to all the potential iterations and innovations. So learning, for example, that you can have a main principle to guide you, but then that you're there to support any iteration that could actually improve the adoption towards that goal, which is treating the atrial fibrillation in all the different connotations or approaches that could be used, for example, in the surgical ablation. And one of the best, episodes I remember is that at some point we had a conference where we were like 4 or 5 surgeons, and all of us were presenting different approaches to minimal invasive AFib ablation. And he was saying, these are all my kind of pupils having different ways to get to the goal, but like all with the same idea and vision. So I think that also trying to build don't build like really building bridges and not dogmatic approaches that there is only one way to treat, but rather than encouraging people to that aspect. What I try when you talk about mentorship, for example, one of the aspects I try to teach is um, everything they see from me is my way of treating, not the way. Whatever technique I use, for example, for mitral repair. But if I may, one important suggestion I always try to give to uh, surgeons embracing a career at this stage, and I think in this era, is about don't see yourself just as necessarily a technical surgeon, but more as a specialist in the valve disease. I have a great opportunity to be involved also in structural procedures. I spend 40% of my time in the cath lab. So I'm mostly a mitral surgeon, but I would say valve as a general surgeon. And I think it's important because rather than positioning yourself as in our, let's say, ivory tower waiting for referrals to come, you proactively are involved in the whole process from medical management to the treatment, which could be surgical, but also transcatheter, and you are actively involved. So one of the things I encourage the fellows is to be more of a valve specialist, if that's one interest, rather than simply a minimal invasive or robotic mitral surgeon.
So you bring up a really good point about training, and not just training of fellows and residents, but you have to continually learn as a faculty member. But the amount of knowledge is increasing exponentially. The techniques and the devices are also increasing exponentially. How do you see being able to train people when you have just this huge volume of information?
I think it's another incredibly important point. And again, the problem is the pathway that you are progressively taking. For example, even in my own experience, when I was initially working at Queen's University, my former institution in Canada, I was mostly focusing on, mitral surgery and mitral clips as like tier approaches. As I moved to St. Michael's, the breadth is so broad that now I basically had to progressively embrace into TMVR, TTVR, of course, TAVIs. I think it really depends what your goals are and what the institution is also capable of offering. And to be completely honest, it depends how much you want to put yourself up to the challenge. Because I must say that it's not easy, as you mentioned. Even if we speak about, for example, TTVR or TMVRs, we have 3, 4 different devices, and it's not easy to remember all the different knobs and actions that you need to the pathway and process you need to follow. But that's really up who you want to be. So if that's what you want to be, you need to keep yourself. I joke sometimes that it's probably it's one of the most exciting but the most stressful time of my life because I have to be almost a fellow every other day to learn new technologies, but still be a staff. So at least when you're a fellow, you're just a fellow and not having the duties or the challenges of a staff. So it is challenging, but I think for me, it's incredibly rewarding, and it constantly provides me with new ideas and new potentially opportunities. So.
Your answer is really great, John. And I'm wondering about the landscape of cardiothoracic surgery in Canada. We in the US, we anticipate a huge shortage in cardiac surgeons, and surgeons are split between super specialized academic centers and then very much more broad-based cardiac practices. Some of those surgeons are still doing vascular surgery versus thoracic surgery. Can you tell us a little bit about the Canadian culture and landscape for cardiac surgery and how you approach training between the super specialization of what you do and then the landscape of what all of our patients really need?
No, it's a great point, Sarah. And I think, as you mentioned, it really depends from country to country. The landscape in Canada, I would say we don't really have many centers, as I mentioned. And most of our centers are actually academically affiliated.
Okay.
So it's extremely unlikely in Canada to find centers that may perform, I don't know, 200 cases a year, or even having, as I believe in the US, it's also a potential option that you may have satellite centers, part of the main, I would say, campus, right? With some, let's say, hub and spoke models where surgeons may go and work. Everything typically happens in the main hospital, and so. I would say that yes, you may have some community cardiac surgical centers, but it's more the exception than the reality. So you end up, as a consequence of what you described, to probably have larger centers where people tend to subspecialize in areas. It's probably unlikely that you are in a center with like more like a fewer people and more widespread practice. We tend in general to be, even I would say in the past few years, there's been a tendency in the recruitment process across the country for more specialized figures rather than broader cardiac surgeons. So it is for sure something that is unfortunately, some of the challenges in Canada related to the access to certain technologies, for example, robotic surgery, or in general, even some minimally invasive procedures that, as we know, can be more expensive. And in our healthcare system, despite we have obviously provincial healthcare systems, but at the end, the challenges are not different from one province to the other in terms of the reimbursement and how we can implement those.
So through time, we have interest in the complete surgeon, not just the surgeon in the hospital, and work-life balance. And specifically, can you tell us a little bit more about how the culture in Canada supports that or doesn't support that? And, how is it different between trainees and faculty?
I must say that the prior generation of surgeons, like many of us, have gone through. There were many, weekly work hours caps, and it was an infinite, time that was spent at the hospital, which I think that was probably an extreme from one side. There are obviously regulations. That are set in Canada. I'm pretty sure that's true also I'm sure it's true for US, it's true for Europe. I see fellows often, regardless of the, shift, so to speak, they attended to. We tend obviously to be mindful of providing them a reasonable balance. But the people who are interested, they tend to, request to, be exposed and see as much as possible because it's sometimes an important opportunity for them to gain as much knowledge. And we need to be mindful of all the different aspects that we need to provide in a work and personal life balance, which unfortunately is not easy anyhow. So I must say that. I think it's important not to overwork our trainees, but it's also true that they also need to learn that once you become staff, you can't simply say, my shift is ended and I'm entitled to have my time off, because if your patient bleeds or has an issue, it's you who has to be called. So I think it's also important that we convey a message that we need to be ready mentally and physically to be able to manage what the expectation as a staff surgeon will be. So I believe that for me, the one of the really exciting part of the work in Canada has been the possibility to shape my career as I was mostly focused on. So really having the opportunity to balance from my clinical to the research. It's really at some point up to me to pause, obviously not for the clinical duties, but whatever type even of clinical or translational work I want to do. So I find that this is it's also one of the reasons why I decided to move to North America from Europe. I was probably influenced. I know that obviously the US and Canada have many differences, but there are some similarities in how surgeons can shape their career in North America compared to Europe. And when I work as a staff in Europe, as much as that was my home country, I was still aiming for that kind of ability to shape my own career as I wanted. And I think this is something that North America can offer to surgeons. Um, but it's hard. It's very hard especially if you're trying to build a program. Um, One of the aspects we didn't touch before is that it doesn't matter how experienced you may be. You move to, for example, a city like Toronto, you have to start from scratch and you have to build again your reputation. So it takes years to get to a stage where you're like, okay, now I've ensured that the program has enough patients flow that I can start focusing on other
Yeah.
aspects. So it's never ending, so to speak.
Yeah. No, I mean, you're not alone. In the last STS compensation survey, that was the number one thing that people would accept in lieu of money is autonomy and freedom of schedule. So it's very telling.
Well, it's also good to hear that you have the same trainees and rules in Canada as we do here with you can't go home if your patient's bleeding in the unit. It's hard to teach. So
Well,
I'm
let's say it's a suggestion.
it's it depends how many hours are logged at the end of the week, right? So I know you enjoy hanging out with your wife, daughters, and your dogs outside the hospital. So what do you do on your day off to unwind in Toronto? What's your favorite spot?
Well, whenever that happens, in the rare times that's a possibility, I must say that one of the aspects which have been, in all fairness, completely, I would say, a serendipity for myself and my wife. We were married and moved together from Italy to Canada. The last thing we're expecting is to find Italians or an Italian community, especially when we moved to Queen's University in Kingston. I believe we were the only two Italians in the city. And Toronto is one of the largest Italian communities. So it's funny for me to say, but we almost don't crave even that much Italian food. We still have our families in Italy because we find incredible restaurants here. The food is great, and many even Italian people we met. So we obviously have a very diverse group of friends, but we really find quite entertaining for many activities we can have. And now with our kid, who's now 6, we can get her more involved in many other activities. Definitely have long winters, so we go skiing. I mean, we don't find the Alps, of course, in Ontario, which is a little of a painful part for me, having skied on the Alps since I was a kid. But otherwise, we really find a lot of also outdoor activities. And I still remain a fairly avid musician, so I have a huge guitar collection. I love hanging out with some friends, and we play in a band. So I still hope I can go back to be having a career in music at some point.
That's great. I can think of a specific surgery chair in the States that's a huge guitarist, so you could do it. But do you
Well,
play with your right or left hand?
I play with my left. I play with my left.
That's awesome. Cherie.
Well, thank you so much for being part of this conversation. And we're so grateful that you were able to join us. And thank you for supporting this Hot Topics podcast series of Same Surgeon, Different Light. And we can't wait to keep the conversation going with you when we meet you in person. But thank you again for your time and for being so candid with your answers.
Well, thank you so much, Cherie and Sarah. As I said before, it's a true honor and incredible opportunity to meet with you and the STS audience, and looking forward to hearing to many more podcasts.
Thanks so much. Have a great evening.
Thank you.
Thank you.
This has been Same Surgeon, Different Light, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT Surgery. And for more information about the Society of Thoracic Surgeons, you can go online at sts.org.